Good evening. I'm Dr. working as critical care consultant at Apollo Vizag. I'm going to talk about today regarding dengue risk stratification and management. Please,
Audible, madam.
Please answer.
slaves traveling from one country to the other, and also the trade of tires used in vehicles cause the dispersal of eggs, which can survive the dry conditions for around 8 months. This is how the dengue is spread around the tropics of around the equator and all the tropical countries. Again, in India, almost in all countries, we see dengue spread over all the countries, all the states of the country, except the Himalayan areas. And you have the monthly or seasonal and month-wise distribution of dengue suspects and positives. That is usually during the monsoon months, we see these cases booming up and our ICUs filling. So this is the Aedes aegypti mosquito, which has which you identify by the black and white bands and the specific antennae that it has, and it is very peculiar in distribution in its habitat, and also it usually bites in the daytime and is spread around the urbanized communities wherein a lot of debris and water are present. So this is the cartoon that is depicting how our healthcare is unable to hold the burden of dengue, and how we are facing the problem, and how we are facing the economic burden because of the dengue, which is preventable, wherein the mortality can be reduced by our risk stratification and management in a protocolized manner. This is the urbanization which has caused a lot of debris in and around our habitats, and also the habitat for the mosquitoes. And this is the transmission cycle of dengue, where it is called vertical transmission. The Aedes mosquitoes they either inhabited the primates in case of forests, and in rural and epidemic areas they are to the humans and again to the Aedes mosquito. There is no intermediary host in these conditions. And apart from Aedes aegypti, you have albopictus, which also causes the transmission of the virus. So this is a single standard virus. It belongs to Fabiviridae and it has 4 serotypes and a genomic structure. It's 3 and 7 structural units. And this dengue manifests all the symptoms and involves all the systems of the body, which I'm going to speak in my next slide. So this is the virological feature wherein the microscopic picture of the dengue virus is shown as depicted in the picture. It is an RNA virus, has a tube, and it has 4 different varieties, 4 dengue virus serotypes. Why it is important is many of the patients do ask us, if I get dengue now, am I going to get dengue the next year or the next year after? So here lies the question. There are dengue virus serotypes which are designated as dengue 1, 2, 3, 4, and this is the structure of the RNA virus. So the question which I put to you, one serotype is believed to confer long-lived serotype-specific immunity, but only short-lived cross-immunity between serotypes. That means if I get all the antibodies to all the dengue virus, that is dengue 1, 2, 3, and 4, then I'm immune to dengue. I think you got the point. That is, if I get dengue 1 serotype antibodies this year, I'm prone for infection with other dengue 2, 3, and 4 virus. So what are the risk factors which are going to determine the outcome if a person is infected with dengue? These are all the added risk factors. That is, if the patient has got young age, is female sex, pregnancy, diabetes, hypertension, comorbidities, high BMI, on steroids, on anticoagulants, and the type of virus, the genetic variants of the human major histocompatibility complex, related sequence, and phospholipid C, epsilon G, and if associated secondary infections are also present. So, what does the dengue virus per se do in the body? When once it enters the body, it starts production, the body starts producing antibodies. This antigen and antibody in turn activates the system, which in turn will cause manifestations of coagulopathy and vasculopathy. The other end of these reactions, where the T cells are activated, the T cells in turn cause the chemical mediators to be activated, that is cytokines. This causes increased vascular permeability and clinical manifestations of vasculopathy, and they result in hypotension and shock, along with the leaking syndrome, that is, which results in pleural effusion, ascites, bleeding, and organ involvement. So I was talking about, here is the macrophages. Here is the macrophages which are getting infected by the virus, and this macrophages in turn, and the dendritic cells, these are nothing but the immune cells that are present in the skin. They in turn release the inflammatory mediators, and the cytokines are activated by the T cells. These inflammatory mediators, they act on the glycocalyx. This is nothing but the membrane which is called the endothelial membrane, which is intact in the normal nature. When these inflammatory mediators act on the endothelial membrane, you have the disruption of the endothelial membrane, and this causes the leakage of the endothelial membrane, leakages in the endothelial membrane. That is how the plasma leaks out. And at the same time, these inflammatory mediators they cause the destruction of the thrombocytes and cause thrombocytopenia. So now we are very clear the inflammatory mediators are acting on the glycocalyx. That glycocalyx is, you can say, children, especially the children, they, we see the heparin sulfate in the urine because of the breakdown of the glycocalyx, which is nothing but a membrane, endothelial or the vascular membrane present in the blood vessels. So now we are very clear what are the inflammatory mediators doing. They are causing the destruction of the endothelial membrane and release of the plasma into the extravascular space. That is how the patient is landing up in shock. So there is a method, they say, but I haven't seen it. They say that the literature says that there is a method wherein you can see how well the barrier system or the endothelial system is functioning depending upon the you measure, keep electrodes here, and you measure, it is called electric cell substrate impedance sensing technology. You measure the resistance, and this resistance in turn is increased by the number of cells, the morphological changes that it undergoes, and the nature of cell attachments. So this is a method where they say that you measure the endothelial integrity. So as I said, there are inflammatory markers, there are the cytokines that are increased, the cytokine storm, as you know. In COVID also we have heard this. So in patients of dengue, in the febrile phase or in the critical phase, there is definitely an increase in the cytokines that are produced when you compare with them with controls or people who are asymptomatic. So if you see the various types of cytokines, the IP10, MCP1, MIP1, G, GCSF, the controls, and in acute phase and in the critical phase with people with dengue as well as dengue with warning signs, these cytokines are increasing. So this is again the depiction of the same, wherein in febrile phase, the platelets are dropping, the AST is increasing, in convalescent phase, even the ALT is increasing, and in the critical phase, the AST and ALT are increasing along with increasing various cytokines. And in convalescent stage, the AST is coming to normal, and the cytokine level of cytokines and the type of cytokines are coming down slowly. So it is all about cytokines, the virus causing cytokine release, inflammatory markers, in turn causing the damage. Then how about a primary infection? I'm sensitized now with some dengue virus. I have an antigen antibody mediated response, and I have my memory cells remembering this antibodies, and a cross reaction to antibodies. If I get infected again, it's a cross reaction. There is neutralizing antibodies and non-neutralizing antibodies. And this in turn, if I'm immunocompromised, I said in the risk factors, histocompatibility of the individuals is also important in the way how you react to the dengue infection. So in certain susceptible individuals, this causes an exaggerated response, which in turn will land us in severe dengue virus infection. So this is how there is a difference in primary response, both in the febrile and the critical phase, wherein the cytokines are very much activated in both these conditions, no doubt. But in secondary infections, the level or the amount of cytokines that are increased is far high than when compared to the primary infection. So how do you classify? And why do you need to classify? That is for triaging and clinical management of the disease and improving the quality of surveillance and to collect epidemiological data globally. So you need to classify the disease to follow the standards. So how is it classified? It is dengue is classified as dengue with and without warning signs. I think the slides are not displayed. Just will come back. Okay, audible. So you have classification as dengue or without warning signs is one category, and the other is severe dengue. Previously, it is being classified as dengue, dengue fever and dengue hemorrhagic fever, 1, 2, 3, 4 classes. So this is no more used because there is every chance that a patient may be underscored or he may miss the severity in this system. So now the WHO has changed the signs or risk stratification or classified it as dengue with or without signs. In criteria for dengue, you have any patient who has visited the endemic area, if he develops fever in 12 days, after his travel within 12 days, you can suspect dengue in him. The manifestations can be nausea, vomiting, rash, aches, or any other viral fever. The other symptoms which are nothing but warning signs are abdominal pain, tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleed, lethargy, and restlessness. Why are we these warning signs? Warning signs, people or patients with warning signs are prone for decompensation at any point. They are more prone for shock. So any patient, more so the patient with warning signs, may progress into severe dengue. That is wherein we see the severe plasma leakage, severe bleeding, severe organ involvement. So this was the previous classification which was used, and now we have changed it to dengue with warning signs, and severe dengue as I told you, severe dengue. So the clinical course of dengue hemorrhagic fever or dengue fever is to have 3 phases: febrile phase, critical phase, convalescent phase. The febrile phase, uh, this graph depicts very well that the temperatures initially you start fever and the fever subsides in 3 to 4 days. In the febrile phase, minimally dehydrated, your hematocrit slowly starts increasing. The initial increase by the end of the 4th day, it falls down. Sure. Sorry, we are back at the febrile phase, have the critical phase, and the recovery phase. The febrile phase, during temperature spikes are seen, the patient is dehydrated, the hematocrit rises, and the viral load is high in the febrile phase. Then the patient progresses. Sometimes, luckily, you may end up here, or you may progress to shock, bleeding, or organ impairment. So here, this is the phase where we need to identify which patients are going into this phase. Early resuscitation, good management in this case will result in decrease in mortality, and you have a reduction of mortality from 20 to 1%, 20% to 1%. Then the recovery phase, wherein the edema comes back, whatever fluid has seeped into the extravascular space is reabsorbed, the platelets start increasing, and you have IgM and IgG present in the serum. So now I think I'm very clear. You have the hematocrit, the dehydration, and the elevated hematocrit, elevated temperatures, and viral load, which is high in the initial phases, that is 1 to 3 days, followed by the dengue or the critical phase. And once is of 7 days, 7 days are over, the recovery phase starts in these cases. So this is the febrile phase, characterized by high fever spikes, as I told you, and this is just a repetition wherein you see the leukopenia and thrombocytopenia in these cases. So always they mention about the tourniquet test, though we don't do often. We just see the petechial rash, patients coming with petechial rash. The tourniquet test is performed by inflating the blood pressure cuff to the midpoint between the systolic and diastolic. Suppose my systolic is 120 and diastolic is around 80, and I inflate the cuff to 100 and hold it for 5 minutes. The test is considered positive when there are 10 or more petechiae per 2.5 square centimeters are observed. I can repeat it. Definitely, it will be usually positive in the critical phase of the dengue. So, as I told, the critical phase starts from the third day of the fever, around fifth, and usually around fifth or sixth day of illness with difference and settling of the fever. Still, some patients, there is a persistent myemia. They have high fevers continuing even at around the seventh or even at the 10th day of the fever. So this is how the hematocrits raise, the plasma is lost in the critical phase of the illness. So then we have the recovery phase where we are happy that he has passed through the critical phase, that absorption occurs, generally improves, the rash develops, and hematocrit stabilizes, and the WBC starts to raise. So what are the tests that I need to send to confirm that my patient is having dengue and at what time? This is very important for all of us. So the initial viremic phase, if I'm able to detect the virus, that is very good. The virus is detected by the RT-PCR. The viremia or the virus is detected by the RT-PCR. The NS1 is nothing but the antigenic protein of the virus, which is also detected during the initial phases of the virus infection. So these are definitive tests for the detection of the virus. Then slowly by the end of the third day, my IgG starts production. There is an IgM in blood, and that can be detected by serological testing, that is by ELISA. Then you have slowly the increase in IgG levels, which indicates that I have developed antibodies. And this is also detected at the same third or fourth day of my illness. This is depicted very well in this picture, wherein the initial viremia which is sensed by the RT-PCR, NS1, which is tested by the rapid test, the IgM, which is detected at a later date of around fourth day starts, it is present. IgG, if I'm already infected, my IgG levels are already present, or if it is a primary infection, I start my IgG level at the day 7. So now I'm very clear that RT-PCR for viremia, the standard card test, which may not be sensitive, but still they are helpful in detection of dengue. And the ELISA method, we detect IgM and IgG. So, what is probable dengue and what is dengue? As I said, if I if the virus I'm able to isolate, if I'm able to detect IgM antibody titers by ELISA or NS1 ELISA or IgG seroconversion to paid sera after 2 weeks with fourfold increase in IgG, detection of viral nucleic acid polymerase chain reaction, all these that the patient has confirmed dengue fever. The probable dengue fever and dengue hemorrhagic fever, a case of compatible with clinical description. Somebody went to an endemic area and he has developed fever. So I'm suspecting that he has a dengue fever. Non-ELISA based dengue or IgM positivity or a positive test or rapid test be considered as due to poor sensitivity and specificity of the currently available rapid test. So, whom do I admit? Already, I told you risk stratification. Who are the patients that I am suspecting that they may go down in case of in the next few days. So, patients with platelet counts less than 1 lakh with the following warning signs: abdominal pain, tenderness, vomiting, clinical signs of plasma leakage like pleural effusions, ascites, mucosal bleed, lethargy, restlessness, enlargement of increased hematocrit, and other patients who require are pregnant patients that are more prone, they are very high risk group, obese, elderly patients, and with other comorbidities. So these are the various guidelines that are given in the Indian National Guidelines for Clinical Management. I have taken up from these guidelines management and CDC guidelines, and you have WHO guidelines. And each country has their own guidelines, like the Sri Lanka, Bangladesh, where the dengue virus is very rampant. Dengue fevers are very rampant. They have guidelines. So, how do I manage? Now that I've identified as patients with dengue, dengue with warning signs, dengue with shock or severe dengue. Now, how do I manage? Initial dengue patients, I can manage them at home. People with warning signs, I'm admitting them at hospital. People with shock or severe dengue manifestations, um, I'm manifesting. I'm sorry for interruption. So we are going with the management of the case, emphasis on careful fluid management. You prefer isotopic crystalloid solution used. In case of shock, you can use colloid solutions, blood and blood products, and platelet transfusions. So there's a cartoon which depicts that these small creatures are causing a big impression on us, and there is a lot of resources and economics involved in this, and the complications, the CNS involvement, which causes every system of the body is involved. The CNS, the gastrointestinal, the renal, the cardiac, and the respiratory, and we shall talk about these in detail. So when the patient comes with hemorrhagic or bleeding tendencies and thrombocytopenia, these are the guidelines that were given by the CDC, wherein you start with 6 ml per kg body weight of crystalloid solutions, and if he improves in the next 4 hours, you de-escalate to 3 ml per kg body weight, followed by 3 ml, 2 to 3 ml per kg body weight, and you discontinue once the parameters stabilize, that is the hemoglobin and all are normal, and you discontinue the IV fluids. So you're giving for 48 hours and you see how the patient is progressing. Then if there is no improvement, the hematocrit start raises, you can increase the fluids to 10 ml per kg per hour. And internal hemorrhage, if you're suspecting, you go to the blood drops. This is the algorithm which is showing the increased compensated shock, that is the pulse pressure has increased more than 20 mm Hg, and there is a hypotension and a high hematocrit values. So this is how you start with higher fluids of 10 to 12, 20 ml. There we start with 6 ml. Here we start with 10 to 20 ml. You see further response, and you come down on fluids every 2 hours from 10 20 ml to 10 ml and 6 ml, and then further see how this progress over the next 24 48 hours, and you discontinue fluids. Here, if the hematocrit rises further, you can go for colloids. We usually use that. But again, our preference is to go for crystalloids only in unresponsive shock, and only in certain conditions we go for albumin, or rarely we use albumin. The blood transfusions 10 ml per kg in case of any bleed. So this is a profound shock algorithm wherein the same, but you use inotropes and see that the mean arterial pressure is more than 65. So why is a dengue patient bleeding? Is it the reason just because his platelets are low? No. There are many other factors which are contributing for cause of bleed in dengue, hemorrhagic fever, or dengue fever. There is a normal coagulation, that is all the PT, APT, are deranged, thrombocytopenia, platelet dysfunction, prothrombin complex deficiency, secondary to liver involvement, endothelial injury, and tick and prolonged APT2. All these factors are contributing to the bleeding tendency in case of dengue. The other, why is the patient having low platelets? One is destruction of platelets by the cytokines, inflammatory markers, or the antibodies against the platelets that are formed during the infection by dengue, or disseminated intravascular coagulopathy, or bone marrow suppression in the early stages. The virus itself causes suppression of sequestration, that is, the von Willebrand factor is increased, or rather, the usage of von Willebrand here. There is a consumptive coagulopathy wherein the factors are utilized, and there is lot of platelets are getting sequestered in the process of coagulopathy. So here is the picture depicting how there is a stress on the blood banks because of one, these per se is causing the demand for blood products, and the second, there is, every patient dengue did not receive blood, But many people who are not indicated, rather are not, who are not supposed to get any blood transfusions are given either out of fear or anticipating complications or causing prophylactically they are giving the blood products. So what is the evidence that is causing, what is the evidence telling us? So this is a trial published in the Lancet in uh, 2000, which says prophylactic transfusion plus supportive care versus only the supportive care in adults with dengue and thrombocytopenia. It was a multi-center, open-label, randomized trial, which shows the prophylactic platelet plus supportive care is one group, and the other group is only the supportive. There is no difference in the outcome. There is no difference in the mortality, and the prophylactic platelets transfusion has no role in case of dengue. This is also one study which says effectiveness of platelet transfusion in dengue fever, a randomized trial that was published in 2013 says um, says almost half the patients who there is no response to high dose of platelet transfusion. Platelet transfusion did not prevent the severe bleeding or shorten the time of cessation of bleeding. So all these trials have shown that there is no role of platelet transfusion in dengue. So what are the neurological complications of dengue virus infection? So as I said, during the period of dengue, you have many patients coming with encephalopathy. Around neurological patients, 21%, 0.5 to 20 patients of dengue can come with neurological manifestations like encephalopathy, encephalitis, especially in the endemic areas. So you have to be careful assessing a neurological patient or a patient who presents with a seizure or an altered sensorium. Mind you, it can be dengue also. So many patients will see bradycardia. We are very worried. Many patients are shifted because of bradycardia to ICU. So what is the mechanism of bradycardia? As usual, as we said, there is a plasma leakage. The plasma leaks into the myocardial interstitial edema. It causes interstitial edema in the myocardium, decreased intravascular volume, which causes altered coronary microcirculation and myocardial impairment, which results in bradyarrhythmias, ST segment depressions, and T wave abnormalities. So, all these things results in many arrhythmias, the sinus arrhythmias, sinus bradyarrhythmias, tachyarrhythmias, prolongation, ST depression. But most common, what we see in all the patients is sinus bradycardia is the common manifestation. So you have bradytachyarrhythmias, SSD changes, SCO dysfunction, AV dissociation, tachyarrhythmias, atrial fibrillation, tachycardias, pericardial effusions, and you see wall hypokinesias. And but the most common is the sinus bradycardia. So I see many dengue cases in corticosteroids. So am I correct giving corticosteroids? The answer you will know by the end of these studies. Corticosteroids for treating dengue shock syndrome is this is published Cochrane database 2006. How it started so from 2006. There is insufficient evidence to justify the use of corticosteroids in dengue patients. So this is one more study. This is also a Cochrane database which was published in 2014. The evidence of trials using corticosteroids in dengue is inconclusive and the quality of evidence is low to very low. So, effectiveness of corticosteroids in the treatment of dengue. This was published in 2018, September 22nd. It's a systemic review. Highly unlikely use of corticosteroids in dengue treatment results in viremia. That means I'm causing more adverse reactions to my patient and any other significant adverse effects or complications issues associated with the use of corticosteroids. So, is there any role? No. The answer for the role of corticosteroids in dengue is no. Is fresh frozen plasma effective for thrombocytopenia? There is no trials which suggest that we use FFPs, but in certain trials they have concluded that there is initial FFPs of around 600 ml may contribute, not will contribute, may contribute to a significant increase in platelet count in the first 12 hours, but not thereafter. So I see the patients at the bedside, the attendants of the patients giving the juice of papaya leaves, the papaya pulp, fruit pulp to all the patients. And is there any role of, or the carry pill what we use, what it is usually written for the dengue patients, is there any role? First, the carica papaya leaf extract, it's a protease involved in the viral assembly. That is how it works. The second thing is it has an antioxidant and free radicals damage properties. So, but will my patient be benefited by carica papaya leaf? The answer is we don't know. The increase in the platelets may not be a significant rise, and we don't know the safety. And on the studies say on the basis the use of carica papaya and dengue cannot be suggested as data of safety was not properly measured and reported in the reported or included in the trials, and we don't know the platelet count to what extent it has caused the increase in the platelets. So we don't know. So I've told you till now how to classify what is the risk stratification, how to manage, what is the role of steroids, what is the role of carica papaya, what is the role of prophylactic platelets. So now I'm with certain questions. What is the name of Aedes? It is also called as yellow fever virus or yellow fever mosquito. And the how long can the eggs survive? They can survive to around 8 months in the dry condition without any water or any moisture. So we have to be very careful. And when they fall at a proper place, they can become the mosquitoes in plenty. Is vaccine effective? Yes, in certain countries it is used, wherein the patient should have IgG, dengue IgG, or else the vaccinated patients, if they have the dengue, they may have an amnestic response and an exaggerated response to the dengue infection. So, people who are getting vaccinated should have an IgG in their bodies so that the anamnestic response is prevented by the next infection, the dengue. Role of FFPs is questionable. Role of prophylactic platelets, no. Role of steroids, no. Role of carica papaya has to be studied, and prognostic markers are high AST, ALT levels, patients coming in shock, patients with low albumin, or patients with severe abdominal pain. All these are bad prognostic markers. So, in conclusion, the course of dengue infection varies from individual to individual and even the same individual from time to time. Early detection of cases, risk stratification, and their management as per the guidelines will give a good result, and it reduces the mortality from 20% to 1%, and your risk stratification reduces the burden on the healthcare system. So here is the case wherein a young female whom we have received the turbulent course in ICU was in ICU for more than 20 days. She had multi-organ involvement, dengue NS positive, coagulopathy, AKI, number of dialysis, and she has coagulopathy complications, rank-related bleeds, and all these were managed in a meticulous way. And we had a very good, and she's been discharged out of ICU. So the knowledge of identification of the case, the knowledge of treating the case, the knowledge of treating in a proper, will not overload the health system, as well as the outcomes are improved by this. Thank you. Any questions? Hope you all of you understood the take home message and the entire Dengue and stations. I am thankful to the Apollo management for giving me this opportunity. Thank you.
Today's